Let me introduce our speaker today. So Dr. Nichols is an addiction medicine fellow physician at the University of Kentucky Department of Psychiatry. She previously served as the palliative clinical supervising faculty for the University of Kentucky Bluegrass Care Navigators Hospice and Palliative Medicine Fellowship. She provides medical director leadership of the BCN Healing Transitions Program. The program's mission is to link and retain persons with opioid use disorder to evidence-based treatment. She has over 12 years of experience in hospice and palliative care, including pain management, usually in the context of serious or terminal illness. She has been a member of the American Society of Addiction Medicine since 2018 and currently serves as an officer in the Kentucky chapter. Her clinical and advocacy interests are in the intersection of palliative care with chronic pain management and addiction medicine. So everyone, welcome back, Dr. Katrina Nichols.
So we'll start with first just talking about pain and how that's processed in our brain after there's an injury. So talking about pain, there's the first thing that happens, there's usually some kind of injury to your body, and that injury will be processed through these nociceptors that then send that signal through fibers and transmit it through our peripheral nerves and into our spinal cord. And there it starts the process of sending that signal up to the brain, as well as the brain signaling, oh, okay, this is something life-threatening or not. But even before it hits the brain and the spinal cord, there's that reflex that happens. Ouch, I hurt myself. Let me pull that extremity away from whatever hurt. And then up in the brain, it's okay, this was life-threatening or not. How did I feel about that? And then it starts sending from the brain through the spinal cord and back to that area of that was injured of, okay, this wasn't life-threatening. We're okay. The pain response can start dampening. And there's nothing happening acutely right now. There's just an injury. And so just remembering that pain can do all of those. Pain is transmitted through that pathway. And it gets more complicated once it starts sitting in our brain and spinal cord, because we also put a value to that injury. So someone who is taking a walk, and if it's a very pleasant walk and they happen to step on a rock, would process that very differently of that injury to their foot versus someone who might be in a life or death situation and they hit their foot and they couldn't run quickly, and they put that value of that was very painful and this is attached to something very negative, and this whole experience was emotionally negative. And then I interpret it a certain way. And so just remembering that there are many steps of that pain pathway, and that will become important as we talk about the management of that later on. Next slide. And so when we're talking about the tissue injury, which is the thing that happened acutely, meaning it happened in the very recent past, there's some kind of pathophysiologic process that happened that your healthcare provider is trying to diagnose and treat. When we're asking all these questions, it helps us to know the quality, the duration, to help us know where to look, because we break down pain types into two basic baskets. One is nociceptive pain, like did it come from the skin, the spinal cord receptors, and some kind of negative injury that way? Or is this something related to our nervous system, like in our large spinal cord or in our brain? When we're talking about nociceptive pain, we also break it down to, is it visceral pain? And that'll be dull, crampy pain in our internal organs, in our belly. Like if someone says my belly hurt, that's why we ask, what does it feel like? If it's a dull and crampy, it's more inside. As opposed to somatic pain, which can be very sharp, like it might be your abdominal wall muscles and not necessarily your gallbladder, for example. But those are why your clinicians are asking those questions. so that we can sort that out. And then, you know, is there nerve damage? We'll usually present like a burning, itching, lightning, lancinating pain. Will tell us that there's nerve injury involved as well. And that could be at your peripheral nerves in your extremities, or it can be centralized in your spinal cord and brain. Now, when I say two types, it's the two types of wear in your body, but then there's also the time piece. And so we talk about acute pain being a recent injury. There's probably an active pathophysiologic process happening or progressing, versus a chronic pain, which is the nociplastic, plastic, and the centralized pains, which are more that something happened at that emotional level, and those neuromodulators that can help dampen that response aren't being sent from the brain down to the spinal cord to tell you that you don't need to send this pain signal anymore. So the brain processing is maladaptive. But you can also have changes at the periphery of those nociceptors that pick up that pain signal that are altered, and they'll continue to send the signal. And so that's what we mean by kind of chronic pain, those nociplastic or centralized pain. And then acute pain, visceral, somatic, and peripheral pain lets us know where to look when we're trying to make our diagnosis.
And then we also talk about pain in the sense of time. So, you know, acute pain is associated with tissue damage that's happening immediately. And we're expecting that that is going to heal. So if that's from surgery, if that's from trauma, if that's, you know, childbirth, it's going to be short-lived. And what we call short-lived, usually your body will take about 3 months to recover from whatever event happened. Next slide. Now with chronic pain, this is a signal that continues to tell your body that there is pain, something negative, after the tissue is healed. And the tissue doesn't have to heal. When I say that, it doesn't mean it goes exactly to the way it was before. But it's already gone through the process of inflammation, scarring, healing. And with chronic pain, there's not any associated identifiable tissue pathology. And again, when I said it doesn't go back to normal. So I should say there's no new, current, or progressive thing happening causing tissue damage. And this usually we use that time frame of it's lasting longer than 6 months. And this is very common. About 1 in 5 US adults experience some form of chronic pain. Examples of chronic pain is chronic back pain, fibromyalgia, migraine headaches. You know, someone who had surgery and they're still having pain at that site, you know, greater than 6 months later. And it goes back to those things that I talked about of, you know, nociplastic, where there's altered receptors that are sending that signal at the site of tissue injury. And then there's the alterations within the brain center as far as trying to process and modulate that, that signal. Next slide. And so this is just another picture to explain that concept. So there's tissue and trauma, and then when you see in the circle where it says nerve injury, that there are some changes that happen closer to where that injury occurs at those receptors that keep feeding this signal to the spinal cord. And then there are changes that happen within the spinal cord and the neurotransmitters and in the brain in that processing that leads to those phenomena I talked about central sensitization. And then stress is related to that. And then that can inform that I'm going to keep sending some kind of pain signal. Next slide. I need to put in a note about cancer pain, because a lot of times you'll hear, you know, is it chronic pain? Is it chronic non-cancer pain? Because a lot of studies looking at pain management exclude patients who have cancer because it's just a different population. It's not related to some back strain, bulging disc, or something like that. So, but let's look at what cancer pain really is. It's related to inflammation and tissue damage caused by this tumor that invades nearby structures. So it can invade and cause tissue damage to the nerves, to the visceral organs, to the musculoskeletal system. It can grow in the bones. So it's related to that. Pain can also be related to the treatment itself. If it's surgery or tissue damage from radiation, tissue damage from chemotherapy, or in the age of, all these immunotherapies, immunotherapies cause your immune system to rev up to attack cancer cells. Then it can also attack like your joints and whatnot and cause inflammation. So those things during the course of treatment or while the cancer cells are growing can be considered an acute pain because there's active tissue injury going on. But it can also be chronic pain. So someone who had treatment already and they're getting surveillance scans and there's no evidence that there's any progression of cancer, but they're still having significant pain, that actually is chronic pain. It's that central sensitization and nosoplastic changes that are happening that are telling the person that they're in pain. And again, time greater than 6 to 12 months after completion of treatment. Next slide. As a palliative care physician, I do have to talk about, pain in the context of end of life, kind of similar to what the hospitalist team talked about when they're talking about pain and hospitalization. Is someone's really sick, there's a great risk that they could die from this illness. That's why they're in the hospital. When we know that it's obvious this person is dying, there is pain involved in that. It's as prevalent as, 75% of people at the end of life will show some signs of pain. And it can be very severe. And with that, and in the hospital wards, that's where we start thinking about we're using opioids to help that pain because we have a short amount of time to relieve suffering, and we know that opioids can work. Now with that, then we kind of have this association and we think automatically, oh, well, hospice and palliative care means opioids for everyone. When really it was because hospice and palliative care started at the end of life. We're talking final days. And so we do use a lot of opioids, and we're very familiar with very high doses to alleviate that pain when that person has very short amount of time. But then we kind of forget and think, oh, well, the risks of any unhealthy opioid use really aren't relevant in hospice and palliative care. And that's not true. At the end of life, when we're talking, days, weeks, they're acutely ill, of course, right? The risk of, oh, how is this person feeling from this? And they might, actually be dependent on this, and it might be opioid use disorder. Yeah, that doesn't matter at that point in time. But just saying that you're under hospice care or palliative care and you're still pretty functioning, and we're looking at months, maybe years of quality of life, it does matter. The symptoms of opioid use disorder and substance use disorder can, be negative to your quality of life. And then I do have to address, the concern that we give opioids in order to hasten death. And what we find is that's actually not the case. There's always going to be a last dose of everything, but someone's going to have a change in their breathing because they're dying. And so there's this ethical principle that we think about when we say the principle of double effect. You know that a medication you're giving could cause someone to decrease that respiratory drive, but we also know that dying causes somebody to stop breathing. And so there's always going to be a last dose, but we're not giving it for the intent to shorten their life. You're giving it for the intent of decreasing if it's pain or if it's really air hunger and you can't breathe, which opioids can help for that at the end of life. And so just saying again, especially since I worked in outpatient palliative clinic in the past, like usually in the context of people getting active, like cancer treatments, they're undergoing chemotherapy, they were just diagnosed that. When we're talking about palliative care specialists are familiar with that pain management during that serious illness and familiar with pain management at the end of life. Hospice in the United States is a specialized form of palliative care that has like this whole bundled payment in Medicare that's specific for people who their prognosis is likely 6 months or less. But it's the same field. So the physicians and nurses kind of get that same training, but that's what a lot of their focus is. But just because someone has palliative care services does not mean they necessarily have a terminal illness and that they're going to die of this, whatever illness is causing pain or whatever treatment is causing pain. And that's something that's, I mean, it's new in the sense of that's been like 10, 15 years. It's not been 40 years. But I mean, it's not a like just this past year concept. And so we do see a lot of overlap with palliative care pain management and chronic pain management, like we talked about in that cancer scenario, because our treatments are just getting better and people are living longer. And so they do have chronic pain. And they're not at the last weeks or days of life. They're at many months and many years. And we still have to think about how is our treatment plan helping this person and potentially causing harm. Next slide. And, you know, this is important because a lot of palliative care specialists or a lot of people who think about pain management with something, some illness that causes a lot of pain, you know, we think of this World Health Organization, this WHO ladder. You've heard about this. There's a 3-step WHO ladder. You start at not giving them opioids. And then if something's causing a lot of pain, usually cancer, then you give them a mild opioid and then really high doses of opioids until, and there is no ceiling, and you keep giving it until you can improve that physical pain. And over in A, in the green part, is kind of the traditional way they thought about it. But then, you know, thinking about it further, it's, well, we need to go towards B, which is in the way is closer to the way we're thinking about it now, is, well, also don't forget other things, because we have that whole nervous system where we can stop that signal and adjust how that pain signal is. And so that's what invasive and minimally invasive treatments would do. So that's when we're talking about things like nerve blocks. Whenever someone says, I got an injection to my back, or I got this spinal cord stimulator or something like that, it's helping to manage pain that way. And then also note the red arrows. You go up, but then when that tissue injury and that acute pain event goes away, you think about going back down that ladder. Next slide. And we want to think about other ways to manage pain, and we're going to talk about that. But we also, you know, another reason to do that, not just because we can have more things in the toolbox, and that's great for everyone, is, and we don't want to rely on just one thing, is that the longer our bodies are exposed to opioids, we can also have this phenomenon that everyone can have. It's not just people who have opioid use disorder, but the chronic exposure to opioids can set in what we call opioid-induced hyperalgesia. What does that mean? Hyper just means more, algesia means like pain. So you have opioid-induced pain. You know, we've talked before that our body wants balance. You know, whenever we give it too much of something, because our body has its own opioids that it, you know, our own opioids, endogenous opioids that it will release to try to help with that pain. But when we introduce it externally, our body is going to reset that thermostat and say, oh, I've got too much of that. I don't need as much of a signal now to say that this is pain. And so this graph just shows you that. You know, we always talk about tolerance. I think everyone's heard that. Well, I've gotten tolerant to that medication. It just doesn't work as well. And that's could be the very beginning. And, you know, everyone's different on how long that is, where someone was prescribed a medication. It was 5 milligrams, and a week or two later, it didn't seem to work as well. It didn't cause as much side effects. It also didn't help as much for the pain. And then now they need 10 milligrams, what we call tolerance. I got tolerant to that medication. But over time, that actually can feed into, gosh, now I'm being prescribed 200 milligrams and my pain is as bad as when this pain first started. That's probably opioid-induced hyperalgesia. It's actually the medications kind of telling your body that, you know, your thermostat needs to go way down. And now something that didn't cause pain before is going to cause pain to you now. So that's what this is. And when it gets really severe, I mean, someone can get delirious and, you know, involuntary muscle movements and those kinds of things, what we call toxic, but that's more for the clinicians in the room. But you can see that if you just either are exposed to the medications for so long, or it's really when we get to very high doses. And so there's a better way to think of this. And before I start talking about how we think about this, and any questions? I didn't see anything in the chat yet, but are there any questions? I know I talked about a lot of different concepts there, or comments. So it said one of your bullet points suggested Medicare is available if someone has a prognosis of death within 6 months. Is this universal policy in the US? For example, 10-year-old, right? So the Medicare hospice benefit would include, anyone with that prognosis. Now, we say they're eligible. There's a couple of things. One is you have to have 2 physicians that agree that prognosis is 6 months or less. And 2, that there's not a treatment plan trying to change that prognosis. So if someone is, receiving immunotherapy or chemotherapy or a bone marrow transplant or something that might give them more time, or at least the reason you're doing it is to extend that prognosis, then they would not be eligible just because they have that diagnosis and prognosis, because of, what the medical treatment plan they're searching for is trying to extend it. And there is hospice for pediatrics as well. Thanks for that question. Any other questions? Okay. All right, so moving on. So, instead of just getting stuck into opioids and everything, it's, what is the magic about palliative care that I think about of why pain management seems to be better when we get involved? And the easy answer is, because we're willing to prescribe opioids and we're familiar with opioids because of all of the training, what I explained there before. But it's also because we're a team-based specialty. So we focus on this concept of total pain, the whole person. How is the experience of having this serious illness affecting them overall, psychologically, physically, spiritually, in the social context? Someone who's very ill has lost their job, has lost their independence, all of those things. And this sounds very familiar, right? Because we know treatment of substance use disorder looks at all of these things as well. And maybe we don't call it pain, but we call it the dimensions of this person and how they're suffering. So this is just another way of a palliative care assessment, and not to say other people don't do this, but this is where our focus and why a palliative care team can help with pain so much. It's not all about the opioids, looking at the psychological dimension, assessing for anxiety, depression, their fear of what's going to happen, that fear of dying or the fear of the treatments. Financially, being sick takes a big financial toll, often a loss of job, changing the family structure. There are things that come up about fertility, legacy, spiritual issues. We usually have chaplains on the team to address spiritual issues, the anger, why did this happen, loss of faith, what's my purpose now that I'm sick, as well as the physical piece. And so if we just talk about just in general pain management, and now I'm thinking about like kind of chronic pain management and hospital ward pain management, instead of talking about the ladder, the WHO ladder, we're now talking about what this is called the trolley cart kind of method of thinking about pain management. So you're thinking about psychology, the psychological support and relaxation techniques. Opioids is what, one of those out of 16. The RF is like radio frequency ablation or some kind of intervention that an anesthesiology, usually anesthesiology, interventional pain doctor can help with. Intrathecal therapy, that's where they deliver medications into your spinal cord, spinal space to help with that. Topical therapy, right, to help right where that pain is at that transduction to affect the signal there. And so there's all of those things that we can do for pain management, physical therapy. So all of that, talking about total pain, addressing total pain, all of those things in the trolley cart, that's what we mean when we say multimodal pain management. And I know that Dr. Anna Marie South talked about that during the hospital management of people with opioid use disorder, but we'll review this again. So there's things that don't have to do with any kind of medication, prescription, or drug like that. It's like physical therapy. Is it just adaptive equipment? Is it, therapeutic exercise, manipulation with a chiropractor, massage, applying heat and ice? In other parts of the physical component include, nutrition, thinking about food that maybe is more inflammatory, or if you have stomach symptoms that don't affect that, and things like acupuncture. Addressing any spiritual needs, talking a lot of it is, meaning and purpose and kind of changing who you are, and like dignity therapy. There are things like energy-based therapies like Reiki and therapeutic touch. And then, psychology. So the things that we're familiar with in substance use disorder treatment, like cognitive behavioral therapy, or acceptance and commitment therapy. Narrative medicine can help a lot. I know in some trauma work, they talk about retelling your story. And, at the end of life, looking at, telling your life story and how that helps alleviate pain. And then, of course, food, water, basics, making sure that those basic needs are addressed, legal issues, financial issues, that there's a caregiver there to help you if your body's not the same. Next slide. And so there's a lot of ways online that this can be self-managed as well. Just looking at diet, that little purple guy that's, Headspace has exploded. Ever since the pandemic, of just realizing people needed to pay attention to their mental health. But those things like the mindfulness meditation can help calm down all of those signals saying, there's pain, something's, this discomfort, I'm going to interpret this as pain and suffering as opposed to a discomfort or a need to stretch. And then, self-management through, stretches, exercise, and those things. Next slide. And then just a word about, cognitive behavioral therapy has been effective in pain management. I know I've seen it used also in substance use treatment. So you think back to when we talked about that pain pathway, it makes sense because, you have a signal and you have a feeling or thought about that. And then that leads to a behavior. So that behavior could be avoidance of doing any activity, which, then avoidance of that makes you start feeling bad because you're feeling limited. And then you start having the thought negatively of, this pain is ruining my life. And then I do less, and then I feel worse. And this pain is ruining my life. And you get stuck in that cycle. And so cognitive behavioral therapy can help revisit, your beliefs about that, think about your thought sentence, and that informs your feelings, and then hopefully trying to address your behaviors. Next slide. When we talk about medications that we're going to add, again, there's plenty of medications that aren't opioids that we can give for pain. So Tylenol, ibuprofen, non-steroidal anti-inflammatories have really good evidence for being very effective for cancer pain, especially in the bones. And so not discounting that. Steroids as well, antidepressants and anticonvulsants would work, just as we looked at that pain pathway up in the brain, and because pain is processed in the brain and in an emotional connection, that's what it would make sense that those would work. And talking about topicals, and then the intervention, there are things when they inject into your joints, or doing nerve ablation that can help. And then just treating the underlying thing that's causing pain, like in the sense of cancer, like get rid of the tumor, radiate it, shrink it, cut it out. And then, or if it's an infection that's causing pain, giving antibiotics. Muscle relaxants can help if spasms are causing pain, and say a trigger point injection and massage isn't enough. So when we are thinking about using opioids for pain, what are the prescription factors that we would be concerned about? So what we do know now, and the CDC guidelines in 2016 try to bundle all of this together so that primary care providers would know what are the things that we know haven't shown great outcomes, and let's not repeat that. So we know that new prescription for like 30 days is associated with down the road taking opioids long term. If it's a new prescription, new acute pain, it might resolve much sooner than 3 months. It might take a few days. So, prescriptions that long, are associated with risk. So that's why you see more prescriptions for like 3 or 5 days only out of the emergency room. We know that high doses are associated with being on opioids long term. Doses, 90 to 120 milligrams of morphine have increased risk of overdose and those patients developing opioid use disorder. Things that also put them at risk of overdose or developing opioid use disorder is if they're co-prescribed antipsychotics or things like benzodiazepines, all the PAMs, diazepam, clonazepam, and all of those. That's been associated with people still being on long-term opioids. And one thing that I want to say about this slide, and I didn't change all of them, but we put down the phrase long-term opioid therapy, but just keeping in mind, we're not really sure how therapeutic it is that someone's being prescribed that. So maybe we should just say like prescribed opioids long-term. And then that we know that initiating, like starting a prescription very early on of what we call a long-acting opioid that extended release lasts like 12 to 24 hours is also associated with a higher risk of accidental overdose if that's initiated early, as opposed to one that only lasts about 2 to 6 hours, a short-acting one. But all of that said, we also have to keep in mind that ineffective opioid dose and acute pain management, if we don't stop that signal soon, I don't want to say stop, dampen and make it more manageable by using everything we can, including opioids, it can increase the risk of chronic pain. Next slide. As far as patient factors that we would look at of increasing risk of an adverse event would be developing another illness like opioid use disorder. So if they had a non-opioid substance use disorder like alcohol, cannabis use disorder, methamphetamine, or if they, had opioid use disorder in the past and they don't have any symptoms of it now, and you expose them to opioid therapy kind of very early on before you've tried other things, then that can increase the risk of those opioid use disorder developing in someone who didn't have it before or having symptoms of and return of active opioid use disorder in the patient. We know that certain behavioral health diagnoses are associated with developing opioid use disorder the longer they're on them, prescribed them. And, I think I gave the KY Open about the substance use disorder assessment and risk tools, but the opioid risk tool for developing opioid use disorder, and I'll show it here, is just a quick way to kind of pull all of those factors in to see, is this someone who's at high risk where I'd have to, be more concerned and follow them, or is this someone at low risk where I still have concern because, but I could maybe follow them a little bit less often. And then just the risk of a respiratory depression event, an accidental overdose. If they have lung disease, chronic kidney disease that affects the metabolism of medications, as well as liver disease or cirrhosis, or if they have, sleep apnea where they already don't breathe several times at night, and you add opioids on top of that, you're going to have an increased respiratory depression risk. And so this is a tool for any clinicians in the room who are curious, or if you're just curious, you could look it up. But this is called a RIO-SORD, or Risk Index for Overdose or Serious Opioid-Induced Respiratory Depression. And someone could score all of this, and you can see on there, it does have to deal with the patient's other health conditions. It also has to do with the medication what is being prescribed? Is it methadone? Is it long-acting, other long-acting opioid? Oxycodone seems to be correlated with a higher risk itself. Benzodiazepines, how much they're prescribed. And then, it does ask within the past 6 months, have they been into the emergency room? That does seem to be an indicator that they'd be at higher risk. Are they going to the, and there's no reason why there, but some things to note, could that be, that's a sign that their overall health is more fragile? Is that a sign that overall maybe opioid use disorder is developing? And, you're at high risk of overdose with that if that's not treated. Next slide. And so this is the opioid risk tool for developing opioid use disorder. For any clinicians in the room, just be aware that this is fairly new, meaning this is revised from an older one. That the older one had a question that was, it was separated into male and female, and was there a history of pre-adolescent sexual abuse question that was always concerning to just bring up in a screener. And for this, investigators looked at, well, let's just look back at factors of people who were prescribed opioids long-term, and what were the risk factors, of this tool that actually they did develop opioid use disorder later. And they found that they could throw out gender, they could throw out that question. That was always really a barrier, and just be very easy of saying it's low risk or high risk. And so this is the one you'll see. So if you ever are working somewhere and you hear somebody bringing up that other one, they're saying, oh yeah, there's an assessment and a way I could screen someone, but I don't like this question, just be like, oh, did you know that there's a revised one that actually is more helpful? Next slide. And so putting this all together, we'll see, what does this look like? What is the clinician, provider going to do with all this information? And so what is somebody who's treating, seeing someone for pain, what are they going to do? What can we expect? And now that you know all of this, hopefully you understand why these questions are asked. So we have to do a comprehensive history and physical, that includes a physical exam. It also, asking all those questions of what kind of pain, how long has it last, let us know, is this nociceptive, is this neuropathic, where in the body might be causing this pain, and what kinds of things I can do. Asking some questions that get a sense of how well is this person's coping skills, and, what we call catastrophizing of, we're not trying to say that it's, that it means that you're going to get less care. It helps us know that we can add more care, because we know that that's something that needs to be improved for the patient so that they can feel better. But that's why you'll see some questions that kind of ask overall, how well do you cope with things, rating your pain. Asking about things about family, asking about physical function, their functioning in society, at the workhouse, do they go out and enjoy things? Making sure that we know about all co-occurring conditions, including behavioral health conditions, any family history of substance use disorder that lets us know there might be like a biologic genetic predisposition to developing a substance use disorder. And then, making sure that you've already looked at the workup that other people have done, any imaging, though imaging, that's especially for chronic pain syndromes, isn't going to be very helpful. What we know is you can x-ray everybody's knees, and all the knees that look degenerative or look like they have arthritis, a lot of those people aren't going to have any pain at all. So that's a little challenging, but to be aware of there, that just because you see something that's abnormal does not necessarily mean that's what you need to attack. And then looking at the CASPR prescription drug monitoring program that lets us know what is other people prescribed that might put them at risk of harm, of either an accidental overdose, or is this a sign of, a substance use disorder, a prescription substance use disorder. Next slide. And then talking about setting pain goals. We're going to start a treatment plan, but we need to be very specific as well what we want to improve. Because unfortunately for chronic pain, it's not going to go away completely, but can we help it be more manageable? So, talking about function, talking about barriers of what that pain is preventing that person to do. Are these realistic goals? If somebody, used to play football, and they're 40-year-old now, and they say, gosh, I used to play football, but then I talked to them and I'm like, well, that was in high school. And you're talking about how your pain now is keeping you from playing football, but you didn't do that for 20 years, So, can we think of something else? Can we think of, oh, I'd like to take a walk around with my grandkid in the park, right? Maybe not run and sprint with them, but I'd like to be able to walk and be there for 30 minutes. That might be more specific and reasonable. So that's SMART goal setting, specific, measurable, actionable, reasonable, and timely. Like, when is this going to happen? We want to see whatever treatment plan we put, we want to see that it'll work within this time frame. And if it doesn't work, we need to revisit that. It doesn't just mean continue more or longer, but putting it in that whole plan. Next slide. And then, talking about quality of life of, this is the PEG, the kind of enjoyment goal, physical, like patient enjoyment goal. I think that's what the PEG is, but, not only how intense is the pain, but how has it interfered in your life, and trying to use that as a measure. Because again, our goal, it can't be zero. We might get there, but if we're always setting ourselves up of, if this is going to be zero, and I'm going to go back to when I was 19 years old, we're not going to get there. And then, so not only are we saying multimodal, do all those things, but we also want to do this in that stepwise fashion. So this is different from the WHO ladder that just talked about medications to prescribe. This is talking about non-pharmacology first, and then adding pharmacology. So for chronic pain management, you'll want to start with things like just movement and setting realistic goals, and physical therapy. The CAM is just complementary and alternative medicine, things like acupuncture, Reiki, cognitive behavioral therapy, trying to affect that perception of the pain signal, realizing, gosh, my back hurts so much, I feel like I'm dying, but changing the sentence, but I know I'm not dying from this, from this back pain. And then how can we get through that moment? Because we know that the pain will spike and have waves of going up and down. How can I get through that moment? And then treating any co-occurring mood disorders as well that affect that pain perception. And then that stepwise, non-opioid therapy, Tylenol, ibuprofen, the antidepressants, the anticonvulsants, if there's neuropathic pain, maybe some muscle relaxants, antibiotics, those things. And then you consider the opioid. Next slide. For people with substance use disorder, and it looks like, hey, we've got symptoms right now, we want to start treatment for that substance use disorder immediately. And this is why. It's because it will make the pain better, right? Like if you're functioning better in your life, if someone's not in that craving withdrawal, what's that word, preoccupation cycle, then that perception of pain can go down. So it's not all about, well, if I'm going to give you opioids or not. Like a lot of times it feels that way, but it's not. It's actually, it's going to make you feel better if we treat that. Similar thing would be to say someone with diabetic neuropathy, if their sugars come down from 400 to 1 to 200, and then they'll say, yeah, I don't have as much pain, I don't have as much numbness, tingling, because my sugars are better controlled. We want to control your sugar because it makes the pain better, right? It's not about like, oh, just because I'm gonna, it's all about the opioid. So just remembering that. And I know I hear a lot from patients that it maybe feels that way, but it's not. For people with specifically opioid use disorder, though, if they're not on an effective medication, FDA approved what methadone, buprenorphine for the opioid use disorder, then start that. For people who don't have an opioid use disorder, but have alcohol or other opioid use disorder. Again, we would not want to start an opioid that can cause increased risk of an accidental overdose or just, developing an opioid use disorder. We want to treat that first. And then you might be asked to see an addiction medicine clinician to help with that, to help figure out, is this unhealthy substance use? Is this, is this enough to say that this is actually an active substance use disorder now, and get the best treatment started, because they'll know what medications and the whole treatment plan could be to see if that could stabilize. And then if that stabilizes and there's still pain and there's a consideration of, yeah, we've done all these things and opioids might really help, then you can start that. But then remembering, all of that stuff about the opioid-induced hyperalgesia, long-term opioid therapy, then you say you're tolerant, and then we start increasing the dose, and that actually causes more harm than good. So, next slide. And then for people who are on medications for opioid use disorder, on methadone or buprenorphine, there can be different strategies like splitting that dose through the day, because the pain relieving effect only lasts about 6 to 8 hours, even though that medication sits on the receptor for more than 24 hours, which is why it's so effective for settling down opioid use disorder. But for that pain relieving effect, it's shorter, so that you might see your doctors do that, and you can increase your daily dose of the methadone or buprenorphine, as well as split the dose. And then sometimes you might see that they'll just add another opioid on top of it for whatever time frame that's happening, like after surgery, during surgery, or whatnot. Next slide. I won't go too far into that, dosing regimen. And then along with that, where you're setting the treatment plan expectations, but then there's also the expectations of what can I expect for how this clinic works and how these appointments are going to work. And so that's where you'll see treatment agreements. So it's, this seems very stigmatizing and you don't like it, but I see this in the cancer center too, right? Like, that you are expected to show up for an appointment, that this is the time that you get your treatment. This is when you can expect a call back. This is when you can expect to get results. So I would say this would be no different. This is saying, this is when the clinic is open. This is how you contact us. This is how you get a schedule. This is, how the refills will be processed. Just like in cancer treatment, it's, you're going to get labs to see how you're doing. You're going to get labs to see how you're doing on this medication if you're prescribed an opioid. And then also that reminder of, this is a trial. Everything we're doing is a trial. And what works today may not work in 5 years. What worked 5 years ago may not work today. What didn't work 5 years ago may work now. So just saying that this is a trial. And because we're doing all of those different therapies, physical therapy, acupuncture, assessment for substance use disorder, intervention, that you might have to see other doctors, you might have to see other specialists to get the best plan of care. And then because it's a medication, if you're prescribed an opioid, it's an informed consent. This is the medication, these are the potential side effects, short-term and long-term side effects of this, and that you understand that. And then, just like we do for everything in healthcare, if there is a risk of there being an emergency, we're going to have a plan. So talking about naloxone and safely storing your medications, making sure that there's not an accidental poisoning from someone else, and making sure that we're not exposing someone who would be at risk if they had easy access to having that medication, to having your medication, opioid medication. Next slide. And then at every follow-up appointment, it is looking at, how are you doing? How are you doing not only functionally and do you feel well? How are you doing following the medication instructions or the physical therapy appointment instructions? All of those appointments, how is that going? And then making sure that we're always assessing for adverse effects of our treatment. And so, that's where, the urine drug screening and the medication counts help us know that, help us know how someone's doing keeping up with their medications, and if there's something else in their system that might be of harm. And then always reviewing the underlying painful condition. Is this improving or deteriorating? If there's something all of a sudden new, it doesn't necessarily mean you just need more medication. Maybe we need to do another full workup. Make sure something didn't happen. Next slide. And then for the clinicians in the room, just having a system in place so that you can focus on how they're doing with the overall plan can get that whole opioid and controlled substance thing kind of out of the way. Just having the system in place of making sure the prescription drug monitoring program is checked, making sure there is a screen done like the opioid risk tool for opioid use disorder, so that you know if there's already a predisposing higher risk of concern, doing the medication counts, refill request history, urine drug monitoring, all of those things. If any of those things show concern, then you know that already. You can address it in 5 minutes. You're not spending the entire visit trying to sort these things out. And then that can help you say, it doesn't help you know if that dose is effective or not. It just lets you know what is my level of concern that an opioid use disorder might be developing, and then do I need to follow up with this person more frequently just to be sure? So that's what this slide's on. Next slide. And then just a sign that, opioid tapering, just like starting, this could be considered, and that would be if we're having intolerable side effects, if that's sleepiness, if that's, severe constipation, itching, or whatever it is. If the person's not improving in their pain and function scores, and we're just adding risk and we're not getting benefit. If there was an adverse event, like a near overdose event, and if there was concern that it's making a substance use disorder, that was controlled and in remission, if we're starting to have symptoms again. And then again, saying if there is a substance use disorder that starts having symptoms again, then, refer and start a higher level of treatment for that. Now with that, if the pain is benefiting from some opioids, and it's decided, okay, well, we're just going to add substance use treatment, then we're going to keep this person safer with maybe shorter fills, maybe once a week. If tapering is just causing more stress and that's causing, that's not helping their substance use disorder, at least doing things in a shorter fill. And then, there's just some ideas about how to taper. Next slide. So takeaway from this, pain is more than physical pain. And therefore, multimodal pain management is the best practice, and that should be expected. And that function is usually what we're looking at, something that is specific, measurable, it's realistic, timely. And then that appropriate monitoring and having a good relationship between the patient and provider is key, and understanding that all those things that seem onerous should be delivered, and the intention should be for the patient. And so with that, I just went at an hour. Any questions from all of that immediately? And I know we have the Q&A next week. What % of people in the US, I don't see who said that. It's a great question. Mike Getz, thanks. From what % of people in the US who you believe should receive multimodal pain care actually receive it? Or can you give us a sense of the trait demographics of who does and who does not receive appropriate total pain management care? I'm sure there are papers that say what % of people actually receive it, but just having done this for a while, definitely less than half. It's probably just a quarter. As far as traits and demographics, payer source is big. Like insurance doesn't pay for a lot of these things. Can't get acupuncture easily. There's only so many sessions of physical therapy that insurance will pay for. I found it's really hit or miss. I can't say that private insurance is any better, but obviously this would be harder for someone who lives in a rural area, especially in Appalachia, who doesn't have access to all of these things. This would be harder for someone who's already working So I would say like 2 jobs, so socioeconomic class, of course, would impact this, because how can you keep up with all of those appointments, physical therapy twice a week, you know, when you have to work. And so the people who probably need it the most are the ones that aren't getting it. You know, people who they don't, you know, you talk about individualized goals of, you know, I wish that this one pill fixed it all, because this is easier than trying to make all these appointments when you're already working 2 jobs and you're hurting because your job is manual, you know, very manual and hard on your body. If that answered your question, if you want to unmute and have a conversation about that.
No, I think you answered it. I was looking for a general sense of how many people receive this. You said 1/4 to 1/2. And then I assume there would be some traits or demographic characteristics of people who do not receive it, such as SES. You mentioned region. What about people who have a substance use disorder? Do they tend to seek out this type of treatment? Are they denied this type of treatment more than others?
Yeah, I would say that there is there's and I don't have a study to prove it, but I know that I've read it and I've seen it. Yeah, it seems to be because it's connected immediately to the prescription part of it first, that a full conversation of all of the modalities probably isn't offered. Like, you get stopped at this one thing out of 16, more than 16, but in that trolley cart, it was 1 out of 16 drawers, right? And it seems like the conversation just seems to stop there. In my experience, that's what I've seen. And then, you know, as far as seeking it out, overall, as far as health literacy, if you have a low health literacy, it's harder to get that buy-in, you know, because that's a lot of education. You know, I spent a whole hour talking about all of these things about pain management and the nervous system. And so it's hard to get buy-in. The feedback that I've gotten from people before is, you know, most primary care doctors only have 10, 15 minutes, and even a specialist might have 30 minutes. And so you're just going to throw out 1, 2 nuggets out there before you come up with a treatment plan. And what I've experienced before is, okay, so we started an opioid therapy, didn't really get a lot of benefits. Now I'm starting to see side effects. And when I bring that up, then it's, oh, you're just coming up with diagnoses now, because nobody said that before, right? Nobody told me that before as we were increasing the dose. And now you're just trying to come up with something to take it away from me. Mm-hmm. And then if I look back, I'm like, oh, because we did all these short visits, there was never a real sit down of, what do you understand about pain? What do you understand about what's going on in your body? All that, you know, like physical therapy, pain education thing. Didn't take the time for that before we just said, okay, here's what I can prescribe for you, and move on. And so it feels that way.
Right. You touched on this, but how would anyone on this call initiate a conversation about total pain management? Like, they go to their primary care doctor who has 10 minutes and they say, no, you need to take into consideration all of these factors because I have a serious global problem of pain. You know, I guess it's up to the primary care doctor to then start referring someone to a variety of doctors. Is that how it would work?
I can't speak for every clinic, but also realizing that your clinic should have a team in some fashion, right? So if that's a medical assistant, if that's a nurse, LPN, a lot of times if you, what I've seen kind of work is when there's been a conversation with the person who has time, not everyone has time, right? But there's that billable time, right? So maybe, you know, when the nurse is rooming someone, could be that opportunity of saying, look, I just want to be clear. I hate that anyone has to say this. I hate this, but it does. It immediately lets someone know where someone's coming from. I'm not looking for a pill. I understand that this isn't going to be a quick fix. I want everything that can be offered, and maybe even throw out there, I know that this is affecting me in all different ways, and I'm expecting that. And then that, because there's such stigma of pain management and stigma of substance use disorder as well, it might help that provider let their guard down and say, oh, okay, what can we look at? Behavioral health, physical therapy, and those things. That, I think that might help. I don't know if
Thanks.
anyone.
I've noticed there are Voices of Hope and BCN people on this call. I'm thinking they may be asking the right questions and be able to refer people to this greater offering than solely dealing with a substance. So that's good information. Thank you.
Well, thank you. I'm looking forward to talking next week. So, from Monica, thanks. What do you think of the growing discussion around shifting patients to buprenorphine for pain management when there is physical dependence on opioids, but the patient does not meet the criteria for opioid use disorder? I'm sorry, I'm smiling and laughing because I know Monica knows that I think I think we should lift. There should be some lifting of the restrictions about buprenorphine. It is showing to be very promising for people who have, opioid physical dependence. It might, decrease that opioid-induced hyperalgesia, just the way the buprenorphine molecule is. In places outside of Kentucky, my colleagues are seeing, great promise with that, of just being able to think about that for patients who have been prescribed opioids long-term at very high doses. There's this thing, though, when you look at the DSM-5 criteria for opioid use disorder, in the context of chronic pain, it is always difficult to sort out when you say unsuccessful at decreasing use and, recovering from effects. So that's very, that's hard to sort out. You would just say unclear. I don't know that they meet that, meet those criteria, but you could say, at least in Kentucky, well, I think this could be the diagnosis, this is in my differential diagnosis there. And so I'm going to start this person on that. But it's just getting legalese. And I know Dr. Finucchi and I talk about this a lot of trying to figure this out in Kentucky, but it is, the criteria, they could still fit in there. They're spending a lot of time trying to keep up with getting their dose and their next dose, recovering from the effects and those kinds of things. And I'll just mention in the chat, Dr. Finucchi's answering, agree, regulation restrictions are very specific to Kentucky in terms of using the sublingual buprenorphine products. Other products like the Butrans patch, for example, can be used for chronic pain, but is not for opioid use disorder because it's such a low dose formulation that it's not going to be effective for opioid use disorder. One thing I will say, for peer specialists, things that have just changed very recently about all of this is, Medicaid before would not allow people would not cover like the Butrans buprenorphine patch for chronic pain. And, we were stuck having to always prescribe short-acting opioids or try long-acting morphine or methadone or fentanyl, even though we had some concerns that could they manage their medication safely, and even for not a substance use disorder reason, just for, memory issues or just health literacy, but a safer medication like buprenorphine would not be covered. Well, that just changed. They put it on the formulary for Medicaid, not the buccal product, but at least the patch, the once weekly buprenorphine patch for people with chronic pain who do not have a diagnosis of opioid use disorder. And then you probably won't see a lot of splitting of dose being written in Kentucky because there are some regulatory restrictions around that, but it's a bit clearer when someone's undergoing cancer pain management or surgery or under hospice and palliative care. Why it's never written that way on the prescription.
Thanks. I think that buprenorphine for chronic pain is a intriguing idea that's not catching on in Kentucky because, even though the regulation kind of allows it, I think people are scared to figure out how to do it in a way that kind of meets the requirements. I also think sometimes stigma plays a role in that for the chronic pain patients, right? Like they think of buprenorphine as something that you give when somebody's developed an opioid use disorder and they're resistant to that notion. Like that's not me, but trying to figure out a way to do it that convinces them this will help with their pain in addition to helping make them safer.
Right. Yeah. And there's so much literature about how it's safer in kidney failure, liver failure, and it's been effective with pain and shortness of breath in palliative care. So, my thoughts about it is yes, and trying to get it to be more accessible.